Ready? Okay. Thank you everybody for coming out. We're going to get started. So this is just an overview of the curriculum renewal that's starting in July of 2019 for the entering class. And all of you are currently in our school, so you're saying, well, why should I even bother? Well, for one, free pizza. But it also helps if you're ambassadors for admissions, if you're recruiting people for people that you know, and because a lot of times we've piloted things with our current classes, and some of the things that apply later on we will probably be piloting with your class in your third and fourth year as well, and so some of these might be a preview of things to come for yourselves as well. So this is our mission and vision statement. It's our North Star. It's what we use to guide everything that we do in the curriculum renewal. And I'm grateful for student participation in our curriculum renewal project and the ongoing efforts to develop both the curriculum and the assessments that we're using. But we say that we want to develop culturally competent, clinically skillful leaders in the community, and so everything that we do is directed towards that. As we've said before, the reason that we're going through a curriculum renewal is that things change. Not just the content of medicine, but the environments that you guys are going to practice in. When I was a medical student, I did everything. I did IV placements, I did Foley catheters, I did everything on the floor. And now there are special teams that do all the phlebotomy. There are special teams that do all the catheter placements. And that's for patient safety and quality improvement, but it means that you guys have less clinical experiences than your predecessors. And yet, when you hit the ground running, internship year, people expect you to know things despite the fact that you haven't had the same level of clinical engagement as your attendings. And the reality is we have no control over that. That comes from the hospitals themselves, and that is often mandated to them by Medicare and other federal agencies. And so we're all just responding to those environments. Also, the standards of care change. So when I was a medical student, ultrasound was really something that you used to look for clots and that you used to check on babies. And now bedside ultrasound, point of care ultrasound is becoming more and more standard of care. As a resident, when I do injections for large joints, I learned to do them based on landmarks, and that's how I do them in my practice. By the time you guys are out in practice, even with a normal size patient with a normal BMI, you'll still be expected to use ultrasound to do joint injections, and that's the direction that things are going in. So we have to adjust to the changing environments and to the changing best practices that are out in the community. We also want to make sure that our curriculum is as closely aligned to our mission and vision statement as possible. And in our mission statement, it says that we are developing leaders. If we say that we're developing you as leaders, then we have to have it in our curriculum. I'm going to guess that everyone in this room has been in a room with a bad leader. No? Just me? Okay. But that means that someone has to teach you, how do you manage teams? How are you a good team player, a good team member? How are you a good follower? And how are you a good leader? Because you'll have to play all of those roles as part of the medical team. And so we want to have that explicitly present in our curriculum. And we've already started that. When you look at your emotional intelligence training, when you look at your bias training, all of those things are directed towards those goals. The fact that you do team-based learning, I know everyone loves TBLs, but all of that is directed towards conflict management and getting used to how do you manage things when everyone on the team is not necessarily your first choice, you're not necessarily their first choice. How do you collaborate for a common goal? And that's part of leadership. So some things are not changing. We have two tracks. We have a PBL track and a traditional track, and you guys merge in your clerkships into common tracks and rotations. That's not changing. But both tracks in the pre-clerkship years are substantially changing in terms of their format. So in the new structure, this is the overview of how things are structured as far as coursework is concerned. You'll have system blocks. You can think of those as modules in clin medicine. It's parallel to that, very similar. Intersessions, which are new. Osteopathic clinical skills, which we'll talk about in a moment. Longitudinal project-based courses, which is community service learning and leadership, as well as medical scholarship, and bridge weeks. So what are these things? So currently, in our current curriculum, you go through systems. In year one, you're going through normal histology, normal anatomy, normal physiology, and you go through cardiology, pulmonology, renal, et cetera. And then in second year, you go through abnormals. You go through pathology, pharmacology, clinical medicine, again, but through cardiology, pulmonology, and renal. In the new model, there'll be one pass. So you're constantly cycling through normal, abnormal diagnosis and treatment. And what that does is it brings into proximity what is the application of the basic sciences. Why do you have to know histology? Why do you have to understand biochemistry? What's its relevance? And so instead of having that separated by a year, that could be separated literally by a couple of days. And so we hope that'll make it more obvious what the relevance is. And in the creation of the schedule, it actually removed a lot of redundancies, because a lot of these second-year course directors were going back and spending time reviewing content because they recognized that it was a year away, but that you needed that foundational information in order to take the next step in your learning. So every block, every system block will have anatomy, biochemistry, the clinical medicine, ethics, professionalism. The written portions of what would have been in your OMM courses and on doctoring will be in your system block exams. And so all of that goes into your blocks. So that includes prevention, that includes pharmacology, pathology, et cetera. Intersessions. So periodically, and we'll show you a picture version of the schedule, there will be intersessions, which are breaks away from some of the common topics. So you're rolling through system blocks, and they go through rheumatology and dermatology, brain and behavior, endocrine, et cetera. And you have your longitudinal courses, which are community service learning and leadership and osteopathic clinical skills. When you have intersessions, everything stops. The only thing that you'll have at those times will be the intersessions themselves. And there are 3 different intersessions that will take place. You'll have end-of-life care, and that's an expansion of our current course of death and dying. Death and dying is currently a 2-day course, a seminar, and the students love it and say it's great content, but as you can imagine, it's very heavy material, and sometimes the students say they'd like more time to process that material. So it wasn't that we were necessarily adding a ton of content, it was that we were giving that content more room to breathe and having more time for students to reflect and have time to digest the information. The things that we hope to really expand in end-of-life care, some of which is already there, is advanced care, advanced planning, hospice, palliative care, but also to deal with death at every stage of life, not just the geriatric population. The reality is people die at every stage. So you can have still deaths, you can have neonatal death, pediatric, adolescent, young adult, as well as geriatric. And how do you manage all the components that go along with that? Then we'll have human sexuality. And this is to deal with normal, healthy sex lives. So I've heard it said that if your sex life is going well, it's 10% of your life, and if it's not, it's 90% of your life. But your patients are going to want to talk to you about this. It affects their health. And there's actually appropriate evidence-based practices relative to sex. So we want to make sure that students feel comfortable with these topics because they're sensitive issues, just like end-of-life care is. So how do you broach these topics? Giving you some exposure to the breadth and spectrum of human sexuality. What are your own biases? We're shocked to find out how many young people think that old people don't have sex. They do on a good day. How many people with disabilities don't have sex? They do. Obese people have sex. And what does it look like in terms of what's appropriate when there's dysfunction, and how can you help your patients? And so being cognizant of that, and what are your own biases that you're bringing to the table relative to your patients and your own assumptions. I had a patient one time who had a congenital disorder, a TAR disease, and so he didn't have arms. And one of his doctors says, well, we're going to put you on this medication and it's going to cause erectile dysfunction, but you're not having sex anyway. And he's like, I have a master's degree in social work. You're making a lot of assumptions. Actually, I do have sex. So recognizing the biases that people bring to the table so that you can manage them better and give better care to your patients. And lastly, health system sciences. This is a new branch of medicine that's becoming more popular and more consistent in undergraduate medical education. This deals with the business of medicine. What are the different healthcare delivery systems? What are the different payer systems, not just within our country, but globally? And how did we come to the ones that we have, and how does it affect how you practice as a physician? How does it affect quality improvement and patient safety? All of those things go into health system sciences. We actually have 2 weeks of those, one that takes place in your pre-clerkship years and one that will take place in your clerkship years. Relative to our current students, we'll probably be piloting a program like that in your 3rd and 4th year, and so you'll get to see some of that content as well. Then we have osteopathic clinical skills. What's that, Dr. Channell? Well, I'll tell you. So I've already told you that we're moving all the didactic content from OMM and on doctoring into the system blocks to have integrated exams. Well, we're transforming what our clinical skills and procedures courses look like. So the current labs of OMM and on doctoring, the part that I can actually watch you do in terms of your clinical skills, your ability to take a history, your ability to do a physical exam, your ability to do a structural exam, your ability to do OMM, your ability to do procedures like IV placements and blood draws and immunizations and point of care ultrasound, all of those things that I can watch you do are osteopathic clinical skills. And so those become longitudinal courses. So anything that is observable goes into that grade. Anything that I can test with a written exam would go into your system blocks based on the timing of when that content takes place. And we've tried to organize that content to align with the system blocks as much as possible. So we have a couple of new courses. One is Community Service Learning and Leadership. We already have Community Service Learning as a 2-week course in your 3rd year. It's a required rotation/course that's a partnership with our AHEC partners, which is Area Health Education Centers, which are federally funded programs throughout the country, and we have one in South Jersey that we're partnered with. So these longitudinal courses is an expansion of that. We took some of the things that were previously in on doctoring, like ethics and professionalism, like some of the leadership training and things along those lines in terms of communication and interviewing skills, and we're moving it into community service learning and leadership. So it has 2 components. One is looking at community-based participatory research. How do you do a community assessment? How do you figure out what the community needs? It doesn't matter whether you're going to an underserved area or not. For your community, as a leader, how do you know what the community needs? So that becomes part of CSLL. Looking at how do you contribute to being a member of a team. So there's a lot of team development in this course, as well as doing health promotion interventions. So it's doing the community assessment as well as doing an intervention. There's some of that now in our 2-week course. We really want to expand that content and make it more robust longitudinally. And then, of course, there's a leadership component. So in this course is where we deal with cultural competence, and this course is where we deal with leadership and conflict management, and how do you manage a team. In any team, you're not just going to be working with other doctors, you're going to be working with social workers, with pharmacists, with physical therapists, with phlebotomists, with respiratory therapists. All of these people are contributing to the care of your patients, so how do you work and manage those relationships? Another new course that we're going to have, also longitudinal over the 4 years, is medical scholarship. And this, again, this is content that we're currently teaching that we're simply expanding and deepening in terms of the requirements for students. So this is where you really learn about medical scholarship, medical informatics, epidemiology, biostatistics, general research design, quality improvement, compliance training, scientific communication, both written and oral, and evidence-based practice. Evidence-based practice is going to be in your systems blocks as well, but the fundamental concepts of that would happen in your medical scholarship course. Oh, I'm sorry, one thing I didn't mention, as part of the requirement for medical scholarship, every student will have a written scholarly work that's a requirement to graduate. Now that can be a case report, a literature review, it can be longitudinal research that they do, and a preview that can be cleared by IRB, but you don't have to execute a prospective study to graduate, but you do have to have a literary work. The things that all of those different types of projects have in common are a clinical question, a literature review, a hypothesis, and a discussion and conclusion. And so that will be a requirement for graduating seniors. So here's what a week at a glance might look like. Everywhere you see module group learning, think of that as your current lectures. They may be lectures, they may be team-based learning, they may be a flipped classroom, they may be Socratic circles, but that's where the class at large is coming together. And then you can see that you have OCS, which is osteopathic clinical skills. The layout hasn't changed a whole lot. You still have history and physical diagnosis here. You still have your OMM here, and then procedures. Over the last year, we've made some requirements of procedures that students have to show proficiency and competency in, to ones that we expect them to get some exposure to, and to some that are just simulation. And so the ones that are required are going to start to be taught in first and second year and have multiple points of practice and testing. And then, of course, you have time for self-study in small groups. So on a rotating basis, this is for one particular student. So right now we have case-based learning on Mondays and Wednesdays. That'll still be true. But for an individual student, they would only be attending one of those case-based learning sessions. So when you're not in case-based learning, you might be in a procedure lab. And on a rolling basis, you would rotate on Wednesdays between case-based learning, community service learning and leadership, and medical scholarship longitudinally. So you're not in case-based learning every week, you're not in CSL every week, you're not in medical scholarship every week. It gives you time to complete assignments or to meet with your groups and do other things in between. And finally, we have what we're calling bridge weeks. And the bridge stands for building skills, reflection, integration, development, goal setting, and evaluating. All of our bridge weeks are ways of coming back to content that the students have learned to date and giving more formative feedback along with summative feedback so that we catch struggling students earlier. And if you're doing well, but we think you can do better, we give you that feedback earlier on as well. Our goal has always been and continues to be to make you the best version of yourself. You're not competing with the person next to you, you're competing with yourself and with your own potential. And that's our goal, is to make you the best version of yourself. So here's what a schedule would look like. So my greatest achievement here is that anatomy is front-loaded. After orientation, students will spend 9 weeks just doing anatomy, yay! Which will, of course, will make OMM doctors very happy that you will have had a full pass of anatomy before you really get into the depths of OMM. The only other course you're taking during that time is osteopathic clinical skills. And if you can remember first year, in those first few weeks, you're like, what's a clavicle? It's really landmarks, some basic concept, nothing particularly complicated, but just starting to get your feet wet. Then you have your first intersession here, and as you can see, nothing else is happening during that time. It's just the intersession. So the first intersession is an intensive week of medical scholarship, and think of it like fundamentals, basic language, basic jargon and nomenclature that you need to understand so that you can move forward longitudinally in medical scholarship. Then you have your fundamentals, just like you have fundamentals 1 and 2 in first year and second year, you'd have fundamentals here. Again, what is the basic terminology that you need to understand histology, to understand pharmacology, et cetera. So this is biochemistry, biomolecules in cells, as well as immunology and disease processes are happening here in fundamentals. During that time, you continue to have your osteopathic clinical skills. You start your community service learning and leadership and your medical scholarship. The first system block is rheumatology and dermatology, which we think is a great way to start because it's so broad. Rheumatological disorders really tap into what you just left from fundamentals in terms of immunology and disease, but affects all systems. And it also gives an opportunity to talk about dermatology, which is also a major factor in rheumatological disorders. Oh, excuse me. And then you have your first bridge week. That bridge week is a TOSCI, which is a teaching OSCE. Students during the semester would have done a video and been recorded doing a standardized patient encounter. And so during that first bridge week, you'll meet in groups and go over that encounter and get some feedback on how you did. You'll also start to do some practice exams from the MBOME to get used to board-style questions even more than your exams. And then you have Christmas break. In the spring, your next module is brain and behavior. Brain and behavior is neuroscience, psychiatry, pain management and addiction, and a little bit of musculoskeletal, whatever's left over from anatomy immersion. And I'm really excited about that because it really brings together all the neurotransmitters and neuroscience together with psych and pain. Then you finish that out and you have your second intersession, which is Health System Sciences Part 1, which again is healthcare delivery in the business of medicine. And then the last block of first year is cardiovascular. And then you have a bridge week here at the end of the year. That bridge week starts to have COMATs. MBOME has new subject COMATs. And so students will take subject COMATs in probably anatomy, physiology, biochemistry, and I think pharmacology. But they'll have 4 subject COMATs. And again, to see where you are and give you feedback of what are your weak areas now that you've gone through several blocks of information. And then summer break, because summer break will now be about 6 weeks long, down from 10. In the fall, students come back and do, actually it should be HPN, hematology, pulmonology, and nephrology is a block together, and that's the first block of the fall semester. And then we have endocrine and reproduction. So what was women's health in the second year is now being put together with endocrine, and it's not just female reproduction, it's male and female reproduction next to and integrated with endocrinology. The next block after that is gastroenterology and nutrition. Then you have winter break. You come back and have human sexuality, which is purposely taking place after endocrine and reproduction. And then you have another bridge week. That bridge week is actually a high stakes bridge week. You'll have to pass several station OSCE, that's sort of a mini capstone, in order to move forward into clerkship. And you'll have to demonstrate proficiency in another COMAT that's national that has a benchmark of how you're doing in terms of your basic sciences. But that's also a great practice and replaces what's currently the ComSci in practice for your boards. The last block of second year is lifespans, which is pediatrics and geriatrics. And the last intercession is end of life care. And then you go on to part 1 boards. Yay. Third and fourth year doesn't change a whole lot. There are a couple of significant changes. We're constantly doing quality improvement and maintenance and making sure that our hubs are comparable to one another and constantly elevating the requirements. Some of the things that are changing. So currently we have a clerkship clinical skills orientation week. It's 1 week long. It's not considered a course. We're expanding that to 2 weeks, and that will be considered a course. Additionally, currently, as part of your core rotations between third and fourth year, you have to take 2 out of 3 areas, cardiology, pulmonology, and ICU. Between your third and fourth year, you have to take 2 of those. We're changing that to say in third year, you have to take either cardiology or pulmonology, and in fourth year, you must take an ICU month. Now, that ICU month can be any brand of ICU. If you know you want to be a surgeon, you probably look for a SICU rotation, and it doesn't have to be done in system, so it's selective and can go out. If you know you want to be a pediatrician, then you're probably going to look at a NICU because you know that that's the direction. That's happening in fourth year, so by then you should really know the direction that you're planning on going in, and you can tailor your ICU experience to what you're planning to go into. And lastly, we're going to be developing a residency boot camp. So again, we talked about the fact that there are a lot of things that you're just not allowed to do often as a student, and yet when you become an intern, people expect you to know how to do a lumbar puncture. When you become an intern, people expect you to know how to drop an NG tube. So there are things that we know, of course your residencies are going to train you, but we want you to be able to put the best foot forward. So we're going to have a residency boot camp to give you some experience and some exposure to those things before you start residency. By the time you get to residency boot camp, you'll be all matched, you'll know where you're going. There's no competency exam to graduate. It's really pass, fail, and attendance, but it's really to give you that leg up so that wherever you go, they go, wow, those Rowan students, wow, they're really trained well. We want more of them, okay? So you're always paying it backwards, paying it forwards. For the students behind you, you're relying on the students ahead of you. Reputation matters, and we want you guys to be able to put your best foot forward. So third year, again, third year doesn't look much different than it looks now. We have expanded clerkship clinical skills. We have all the requirements that we had previously. You have a bridge week here. These are the same bridge week, half the class going here and half the class going here. We're still trying to work out health system sciences. We'll probably split the class in half or find another point break for health system sciences too. But this is really an expansion of what we're doing now, which is that currently now for our students, and has been for some time, you have to pass an internal capstone exam. It's essentially a practice complex PE. And so all we're doing is finding a concentrated place to put that. Currently, we pull students off rotations to do that. We don't want to do that. We want your rotations to stay intact and to not compromise any of that. So we're making it a scheduled place in the curriculum for that to take place. And then, of course, you have your course elective here. In fourth year, you prepare for boards, you have health systems 2, and then you have your flex time, residency clinical skills, and then yay, graduation. And then your short coat goes from a short coat to a long coat, and you're a doctor faster than you think. So overall, we're going to a single pass integrated systems-based pre-clerkship curriculum, intersessions on critical topics. One thing I want to clarify relative to PBL. PBL will still stay double pass in their systems, but everything else pretty much still applies to them. They'll have their own version of osteopathic clinical skills, meaning the format of where their grades go and what counts in terms of procedures, OMM, history taking, and physical diagnosis all go into that OCS. Their sequence will be different than traditional track because their sequence is lined up with their blocks, just like the sequence in OCS for traditional track is lined up with the traditional track blocks. They will have their own version of medical scholarship, but they will participate fully along with the traditional track in community service learning and leadership and in the intersessions that we have. Students will have required scholarly work as a project, as an individual, and group scholarly works for community assessments and interventions for community service learning and leadership. And as always, we're constantly trying to evolve and expand our leadership training as part of our mission. And lastly, of course, that we're going to have our residency boot camp, which we hope will be a lot of fun. One of the things that we're talking about is trying to have tracks of those boot camps, so that if you're going into primary care or internal medicine, there might be one track. If you're going into surgery or something that's more procedure-based like ER, there might be another track based on the expectations of where you've matched to. But we'll see. All in all, we think it'll be a good time. Thank you. Questions? Yes?
Can I just say that?
Yeah, please. Oh, wait, go to the mic, I'm sorry.
Can you guys get to the mic, please?
Thanks, sorry.
You can pull it off that stand.
You can pass it around.
So how is tutoring going to work? Because currently now the students have already taken the courses and they help us like as first years.
So the first year is going to be difficult all around. The first year is going to be difficult because you're going to have faculty who are teaching the old curriculum in year 2 and the new curriculum in year 1. So if they look stressed out, please be nice to them. And that's going to be a challenge that we're working on in terms of tutoring. After that, everyone will be in the same situation because they will have gone through the curriculum. Other questions? Sorry?
So along those same lines, has the school ever thought about just having a tutoring center where like maybe one of the rooms is dedicated to just staffing like a tutoring center like many other universities have?
I have no idea what you mean when you say that.
So I worked in the tutorial center like all through undergrad.
I can't.
Oh, I worked through the tutorial center all through college for math specifically, and I was just wondering if the school had thought about having a tutoring center, just staffing it with a few work-study students so that people could just drop by and get tutoring on the subjects they need.
So when you say staffing it with work-study students, so our tutoring center is currently staffed by work-study students. The tutors are paid tutors.
Yeah, I think the difference is like you have to set up an appointment with them versus just having somewhere where you can go if you have a question at that point. Like a dedicated kind of room that people go to. Just an idea.
That would be all the faculty for all the subjects at all times available 50, 60 hours a week.
Okay.
No, we have never considered that or thought that was the best use of time. Students are in class, they're supposed to be in class.
Oh.
And so we've scheduled things after hours and to coordinate with available tutors.
Yeah, it's just an undergrad is just staffed by students like at certain hours. It's not all the time. So, but that wasn't really my main question. I was wondering though for the residency boot camp, as far as like the clinical skills, the school thinks that we should get before we start our intern year, or would be nice to have. Is there any plan for people who are currently third years or fourth years that maybe we could, I don't know, have one of those as well?
So one of the goals is to try and pilot that program before the entering class of next year gets to fourth year.
Okay, thanks.
Great. Other questions? Make a dash for it.
I was just wondering, with the lengthening of like clinical skills week and all that kind of stuff between third and fourth year, or any rotations lengthening or shortening specifically? I understand that you said, you're trying to kind of changing the cardio poem and then the ICU, but any specific lengthening or shortening of any actual rotation, like is family med still 8 weeks, like all that stuff staying the
All
same?
the other rotations are staying the same length. One of the reasons that we started the year earlier was so that we're not packing more into the same amount of time, which is why the school year is starting in mid-July and adds 2 weeks. We also were able to save a lot of time in removing redundancy. So one of the reasons that we're able to do the bridge weeks and that we're able to do some of the things that we're doing in terms of intersessions is because when we went through the content, and now content is, say, happening, basic sciences to clinical medicine is happening on a Monday, Friday, or Tuesday to Tuesday, it really allowed us to pull out several hours of redundancy in the clinical content, which made room for that. We really looked at the content. One of the things that you can't tell from my presentation is that students will be starting clerkships about 8 weeks earlier than they currently are, even after giving additional time for board prep time compared to our current students. They're still starting a couple of months earlier. And that was one of the goals that we had, was so that you could complete your core rotations earlier and then take part 2 of your boards and your PE earlier, so your residency applications are completed earlier. It did, again, one of the things that's not visible there is there's actually an extra week of vacation during the 3rd and 4th week, and that really has more to do with the structure of balancing out time. But no, there was no shortening of core rotations.
I'm just curious about if the single pass effect has been really shown in like the research. Is that like where all the trends of medical schools are going, that the single pass effect is really advantageous for boards or, you know, success in the future?
So there's no study that there's one that's better than the other. A lot of schools are moving in that direction. So we probably looked at about a dozen schools nationally, and what we did was we looked at schools that were top rated to missions that are similar to ours. So who's dedicated to primary care, who's dedicated to underserved, who's dedicated to cultural competence. And those were the schools that we looked at, both osteopathic and allopathic. And a lot of them have moved to single pass. I know of schools that are moving in the opposite direction, that are single pass, that are going in the opposite direction. I really think that what it comes down to is making sure that you're really going through your curriculum with a fine-tooth comb and going through an overhaul. There were certain things that we wanted to do that going to a single pass system allowed us to make room for. Because we lost some of that redundancy, it made room for bridge weeks. It made room for health system sciences. And we thought about having those things longitudinally, but the reality is, and I won't ask who does this, but the reality is when you look at ethics and professionalism falling in the middle of a block, how much of your attention does it get? When you looked at, you know, it sounds good in theory. In theory, it sounds great that you would want this longitudinal thread for certain content, but the reality is that it tends to get pushed to the background, even though it's really important stuff, more important than you know right now. And so really wanting to having dedicated space for human sexuality and end-of-life care and health system sciences. And so it allowed us to have that space. We looked at other schools that, quite frankly, don't have all the same requirements that we have, but we still think that it's important to who we are as a core. A lot of schools don't have, most schools don't have a required geriatrics rotation. And yet, unless you're doing pediatrics, all of you will deal with geriatric patients. That's a reality, whether you're doing OB-GYN or family or cardio or orthopedics. It doesn't matter, you're gonna have geriatric patients, and so you need that foundational training. Doesn't matter what you're going into. Pain management, we've had a pain management course in rotation for years. And now, of course, it's critical to the nation, but we've always thought that was important, and so that stays in our curriculum. We're an osteopathic school. I would love to see our OMM clerkship to be even longer. It's just a capacity issue, and making sure you're with people who are actually well-trained in OMM. A lot of people say they do OMM and they don't. So making sure that if you're on an OMM rotation, that you're really with somebody that you're gonna see a lot of OMM with, and not just here, there, and everywhere. And so we don't have as many electives in third year as some other schools do, but it's replaced with things that we think are foundational to who we are as a school and what your needs will ultimately be in your training. So.
Do you think any of the changes to the 3rd and 4th year curriculum will be available for the current 1st and 2nd years?
So as I said before, we're hoping to pilot some of these programs. So health system sciences will probably pilot in 3rd and 4th year before the rising class gets there. And the residency boot camp we hope to pilot before that comes up. Those will probably be electives and not required, as it will be for those rising students. And so if you choose to participate, great. And if you don't want to and there's other things that you'd rather do, then you'd be free to do that. But we're absolutely, and like I said, there are a lot of things that we're currently doing. You don't recognize it as new because it's all you know, but there are other things that we've been piloting for the last several years in anticipation of this that are already being exposed, you're already being exposed to in the current curriculum.
Dr. Channell?
Yeah.
We have 2 questions that came in online.
Sure.
Will classes be mandatory in the new curriculum?
So I've really spent a lot of time talking to, the answer is some. I really spent a lot of time talking to faculty about lecture, because as you can imagine, sometimes their feelings get hurt when people don't show up. You left your office, many of our faculty are volunteer faculty, and they come over expecting a class of 200 and show up to a class of 25 or 30 students. Particularly when we have specialists or people coming in, that can be very upsetting. My message to chairs and to course directors has been, do not use your political cachet for lectures. If you're doing a panel, that should be mandatory out of respect for our patients and out of respect for people coming out to do a panel. That's interactive and that's telling personal stories and experiences. If it's going to be something that's interactive, you don't have to make it mandatory, but if there's a grade associated with the interaction, like a TBL, a student is, you all are adult learners. You'll make decisions about whether or not you want to take the hit on that quiz or not. But that they be very clear about what's required and what's not, what's being checked on, and what the consequences are of not coming to class. From my perspective, if it's not interactive, I'm not sure why a student has to come to class. And that's my particular take on it. So flipped classrooms, TBLs, panels, things like that, yes, you should be in class because you don't know what you don't know, and we want to make it worth your time. But if it's a straight lecture, I'm going to be hard-pressed to say why that can't be watched as an echo. That's not to say that I personally wouldn't show up to class, because I like live lectures, and listening to things on laptops just makes me numb. But to me, that's a learner's choice. So some of them will be, but we're pressing people to be very clear up front about what's required and what's not. And like I said, when we have the DEA speaker come in, yes, you will be required to be in class, because we're bringing in a DEA speaker. When we have panelists coming in talking about bereavement and end-of-life care, yes, we will require you to be there out of respect for those guests. But outside of that, no, there's no requirements, broadly speaking. There will be some requirements on some things like procedures, because those have dedicated people giving dedicated slots, and as you can imagine, trying to get 200 students in and making sure that faculty are available to train you, yes, you need to show up to those time slots, because those are graduation requirements, and no one has time to double back because you decided to skip lab for the last 6 months and now you're failing. Those will be required because they're labor intensive and require someone else to be present for your training.
Okay, how will the grading system work in the new curriculum?
So we actually just passed this in curriculum for the entering classes, which is that we're moving to pass-fail in pre-clerkship. This has become standard osteopathic or allopathic, that pre-clerkship courses are pass-fail. Pass-fail does not mean that we don't grade you. Pass-fail does not mean that for every exam that you don't know that you got an 89 or a 69. It just means on your transcript, what will appear is a P, an F, an RP, and incomplete, and that we won't have honors, high pass, etc. So you will still know on an ongoing basis what your running score is. So when we shout that mantra to you that you have to have an 85 average, that will still apply, and we continue to monitor to see if that number becomes 82 or 87 or where it falls, but you'll still know where you fall relative to how you're doing overall in your percentage for averages. but on your transcript it will go to pass-fail in pre-clerkship. Clerkship grades will remain the same: honors, high pass, pass, and fail. And again, we looked at national standards and trends and what residency directors care about. In your clerkship years, they want some distinction of how you're doing clinically, and so that will stay the same. There is nothing that's in the new curriculum that hasn't been vetted against other programs and really well thought out as to what value we think it brings to you. I think time is the most valuable thing that you can give to anything and to anyone, and so I take your time very seriously. I don't want to waste your time. That doesn't mean you're going to be happy with everything that I ask you to do, because you don't know what you don't know yet. And I have a longer view, and the Curriculum Renewal Committee has a longer view of what you need. But I promise you that we have looked at everything very carefully, and everything that we have we think is consistent with the mission and vision and what you need to be the best doctor and to be the most competitive. We are constantly thinking about your competitiveness as students to make sure that you have the most choices available to you for what you want to do in your career. Last question, another question.
Yes, I wanted to thank you for all the time you spent, with you and your team doing this over. I can't imagine the countless hours of work you've put into this and how many hours are still to go putting the final details. So I do want to thank you for that, because I think we're trained appropriately now, but I do think this looks like it's going to take it to the next level. So I'm excited to see the results. Along those lines, some feedback I've gotten from students is throughout first and second year, we enjoy the SP encounters. We think they're great learning experiences, but there has been difficulties in getting a timely response and valuable feedback in those SP encounters. And from what you're saying, it seems like that's still going to be a strong part of the new curriculum, but I didn't know if there's been any plan or any kind of changes to maybe increase the availability or the quality or readiness of feedback through the SP encounters at the SP lab.
So we actually just hired, this is talking about our current curriculum as well as going forward, we actually just hired one of our alumni, Dr. Niels Brolis, to be the medical director of the Clinical Skills Lab. And part of his role is to be looking at the SP encounters longitudinally and how they meet all of the competencies that we're looking at. I promise you, on an ongoing basis, we're constantly looking at how we can improve the SP encounters and feedback that you're getting in your encounters. I know that OnDoctoring has currently split up the class and will continue to do so to try and get smaller groups and give feedback on an ongoing basis, as well as giving feedback after the encounters that you're having. I would encourage you directly and through your curriculum rep to talk directly with the OnDoctoring and faculty, course directors, and Dr. Niels Brolis is the medical director for the Clinical Skills Lab now, and he just onboarded, I want to say 2 months ago.
We have one more question that came
Yes.
in online. With an early start date for next year, what does this mean for students who want to participate in a summer research program, some of which end at the end of July?
So that would mean that the student would have to make a decision about what programs they're participating in and what the requirements are. As you can imagine, for an incoming student, you can't miss orientation in the first week of anatomy. And that was something that we also took into account, was the fact that even for SMRF, it's going to affect the SMRF program that we have between first and second year. We're hoping to capture that and working with Dr. Gupta as part of the medical scholarship program. SMRF program spends time doing things during the summer that we hope to incorporate during the school year so that students would have a better time and can use the time that is available in the shortened summer more efficiently for research. In terms of going to other programs, we could look at that on a case-by-case basis, but trying to work with students who are going externally to help them meet the requirements so that they don't miss out on major opportunities. But the calendar is what the calendar is. I mean, honestly, there's several schools that go year-round and have requirements throughout the summer and have summers just as short as we're moving towards. And it's not unheard of. So those are just decisions that people have to make, unfortunately. We think overall it's worth it. Other questions? Yeah.
Hi.
Ooh.
I just had a quick question. For current first-year students, I understand that the rising class is going to come in July is when the new curriculum starts for
So is the second years.
the second year. So the current first years will come back as second years in July as well.
Yes.
Okay, that's just something that
Yes.
several
So
students
that
came to
hasn't
me and asked me
officially
to
been
ask.
voted on by the curriculum committee, but we looked at staggering it, and logistically, it is a problem for several reasons. And so we expect, it hasn't officially been voted on, but we expect the returning second years to come back mid-July as well. What that will do is also move up clerkships, which again, long-term will mean that you can take your Part 2 boards sooner and have more time in clerkships and things like that. Okay? It's great, an important question. You guys have been, I'm scared to end it because you guys have like waited till everyone sits down and then one person will get up and come up and you wait till the person goes all the way and sits down and you pause and the next person gets up. Are we good? Well, I know you came out for free pizza, but I really appreciate your time, and thank you to Christina. I don't know if there's any other students who are participating in the Curriculum Renewal Committee for all their work. We do have student reps and participation, and I promise you they are very vocal and can give you more of the ins and outs. But we really do care a great deal about you and about your success, and we take the time that you spend here and your decision to come here very seriously. We want to give you the best education possible. Thank you.